You guys know the first day that I had to put this on and we took a break, I left it on and I went to the bathroom. And I came back, it's like, oh no. But I guess you didn't hear anything? Okay, good. I'm hoping. That's what I kept thinking. If they don't say anything, that means they didn't hear anything. Whoops. Okay. All right, 2 o'clock, 3 o'clock. I'll see how far I get by 3 o'clock. Or maybe we should just power through it and get it all done today. But I have patient scenarios for this week and next week. But looking at it, maybe it's doable in one day. The other thing is with RET2265, that today's the day for those 3 lectures. Home care patient, difficult airway, and medical or insurance reimbursement. So that might be a lot. But I guess to blast through it, get it done. Then next week it'll lighten up our load. All right, so first scenario gives you ventilator settings. And we need to recommend ventilator changes. So we're in PRVC mode. The set rate is 10 breaths per minute. The tidal volume is set at 650 ml, FiO 2.3, and the PEEP is 5. There are no spontaneous respirations. Patient's ideal body weight, 81 kilograms. It's a big person, right? Ideal body weight. So ABGs are 7.34. PaCO2 is 50 millimeters mercury. PaO2 100 torr. The bicarb is 24 with a +2 base. So what would you recommend for this patient? First, tell me about the blood gas. What are your thoughts about the blood gas? Oh, you need to... Is that it, I guess? All right, so respiratory acidosis. So what do we want to do to make that correct? Is there a formula we could use? Yes. So it's the CO2 from the blood gas times the current minute ventilation.
Times the respiratory divided by.
Oh, okay. Can I underline this? No. Okay. Okay, so if we're not going to be changing the tidal volume, we're good, right? Because we're 81 kilograms and the tidal volume is 650 ml. Can you do a side calculation and let me, oh. So we're okay with that, right? Okay. So since we don't have to change the tidal volume, you're right, we don't need the minute volume in the formula. We can just do respiratory rate and get a quick answer to what the respiratory rate should be changed to. And so it was 50 times 10 over 40. So where did I come up with all those numbers? Does everybody know? Because I don't want to leave anybody in the dust. Brent, you didn't say anything. Where did the number 40 come from?
35 and 40.
That's where we want our CO2. Where did the 50 come from? Yeah, I didn't want to go fast and then lose you guys, so. So it's the current CO2 times the current respiratory rate, and then you divide by your desired CO2, which is typically 40. I'm sure we could complicate matters and do this with a CO2 retainer, and then we would divide by whatever their normal CO2 is. But I'm not going to do that to you on the exam, but you could do that clinically. And then it came to 12 breaths per minute. Okay. All right, very good. Can I erase it? Here we have a patient with neuromuscular disease, atelectasis and pneumonia from the inability to mobilize secretions and elicit an effective cough. So that's what happens with patients with neuromuscular disease is they run into a problem if they get a lot of mucus plugging because they can't generate a strong cough. So with neuromuscular weakness, you don't have a strong cough and you end up getting retained secretions if you get a cold or bronchitis. The mucus just kind of lays in there and it doesn't move. And of course, anytime you have retained secretions, bacteria love to multiply on retained secretions. Then you end up with pneumonia. So that's what happens with patients with neuromuscular disease. Usually they have normal lung compliance. So it's not like you would expect ARDS with these patients. Usually their alveolar capillary membrane is fine. That's not their problem. Their problem is just retained secretions, inability to take a deep breath and cough. Another problem with them is they look great prior to extubation. So when you have them on minimal pressure support, like 5 of pressure support, looks like, yeah, you could extubate, they're going to do fine. You extubate, you take away that little bit of pressure support, and they can't maintain their tidal volume. So they could look great, you extubate, and then they don't do well. Question?
Before you do like your parameters, check and see if they're ready to get extubated, they'll still do well on those too.
Probably not vital capacity. Yeah, probably not negative inspiratory force. If they're weak, their numbers are going to be on the low side. Yeah, good point. So the reason that they crash and burn after extubation is they're just unable to maintain their normal tidal volume. So what could you do instead of re-intubating them? Is there some way you could help them out? Yeah, a cough assist would help. Preventing retained secretions. But BiPAP, so you can give your 5 of pressure support with BiPAP via mask, and they'll be fine with that. I think they'll be really comfortable on just like 5 of IPAP. Or 10/5 would give you 5 of IPAP. Yes. Yeah, very good. Mucolytic CPT, very good. Yes. Yeah. Yeah, that's the bottom line.
So you extubate these patients,
Excellent suggestion. High flow doesn't help much with the size of the tidal volume. So I don't know if high flow would help them. Yeah, so if they need pressure support to get a normal tidal volume, that would be BiPAP. So we have a patient with Guillain-Barré that was trached, has been vented for the past 18 days. You remember what Guillain-Barré syndrome is? And goes to the brain? Oh, what's that?
Wait, it's from Youngberry's ground to what?
Brain?
Youngberry.
GB? Yeah.
Thinking of the other one, mind the ground. Yeah.
Ah, yeah, both lead to neuromuscular weakness. So it gives you the current ventilator settings. How would you proceed to wean this patient from the ventilator? Okay, so some pressure support trials? Okay. Tijin, what would you do? Okay, so they're not assisting at all. Okay. Yeah, it doesn't give us a blood gas. If the set respiratory rate is 10 and the total respiratory rate is 10, that tells us they're not oh, it says normal ABGs. Yeah, so maybe the ventilator is giving them enough support and they have no need to take extra breaths. So how would we figure out if they can breathe? Yeah. So when you put them on pressure support for a few minutes, yeah, you don't put them on and go do other stuff. You would have to stay right there because it's possible that they can't move enough tidal volume on their own. And you'd want to catch that right away. Okay, that's a possibility. Yeah. Yeah. Mhm.
Yeah, you gotta stick around, because I was scared for like, putting respiratory in like 18.
Would it be better to do that with SIMV PRVC rather than full support? Yeah, so to switch over to SIMV, drop the rate to 8, and now you're expecting them to have some spontaneous breaths at that point. Yeah, so that is a possibility. And that's done a lot also. I don't know if you guys have seen that already. Yeah, so it used to be the most common way was to switch over to SIMV, whether it's PRVC or another mandated breath. Give them some pressure support, and then every day you cut that down a little bit more and a little bit more and let them breathe more on their own. But it never gives the patient a rest. So that's why doing CPAP and pressure support trials is better. Because you give it to them for maybe 30 minutes. If you see signs of fatigue, they go back on full support until either later that day or the next morning after they've been rested. Then you do it again and keep extending that period of time. Giving SIMV to wean, yes, it's accepted. You're going to see it a lot. And then the other alternative is CPAP with pressure support trials and just extend the trials as the patient can tolerate it. And then weaning parameters, Rachel, you were mentioning how that would reflect that they're weak. So how bad would their NIF have to be for you to say, you know what? They're not strong enough yet.
The lower aspect of 20 is better. So anything above 20 positive.
So is -10 better? -10 is pretty weak, right?
Yeah.
Yeah, so you want to see more negative than -20. When you, have you guys performed negative inspiratory force?
Yeah.
How long do you occlude the airway to say you got maximum effort? 5 seconds?
5 seconds.
That's it?
I've seen it done twice before, and like the one patient I saw could barely do it, and the other patient was within 2 seconds to leave the meter, but past the 50 mark.
Yeah, so if they're understanding your instructions and then they perform it well, you get a good value. But patients that don't follow instructions very well, you may not be getting the best effort. And if you just do it for 5 seconds, you're not seeing their maximum effort. So like the textbook says, keep coaching them to try harder, to try to get some more deep breaths. Because you'll see after about 10 seconds, they're going to have a huge effort. So I know you were being facetious, but yeah, sometimes 5 seconds is not long enough to see their maximum effort. But don't just occlude it and don't say anything.
Like that. She wasn't really following instructions or not understanding them maybe.
Right.
Like she did in the beginning, but then she stopped. You still extubated her. I'm like, are we sure? Because we weren't really getting like a accurate result. I didn't think so, but I mean, she extubated fine.
Oh, yeah, that's the other thing with weaning parameters is a lot of times they don't predict how well the patient will do once they're extubated.
That's awesome.
So that's a good example of it. Yeah. So we talked about the T-piece trials. What about auto mode? So that's going back and forth between spontaneous breathing and full support.
So PRVC goes with volume support, right?
Yes. So it's possible they could just stay in PRVC all the time, not initiate any breaths. Yeah. Yeah, you want to see them staying in CPAP all the time. No, that's a very important question. I'm glad you asked it. Exactly. Yeah. And then volume support, is that a good idea? Giving different levels of pressure support to target a tidal volume? Okay, so let's say they're triggering spontaneous breaths. Okay. So in volume support, if the ventilator is using like 20 of pressure support to give them their tidal volume, you can't really extubate them at that point. So with volume support, you may have to do the extra step. You might have to go from volume support to pressure support with CPAP. Give them just a straight amount of help for each breath and see what their tidal volumes are before you extubate. Pressure support, I don't know if anybody's using it. Anybody's been in the second floor ICU at Memorial? Are they using it? Volume support.
No.
I've only.
You
seen
have
it-
seen it.
seen it
Where?
at
Oh, really?
volume support.
You have? Okay. Oh, okay. So it's being used once in a while.
And I came and asked, you, I was like,
Ah, that's right too. All right, and we already talked about BiPAP post-extubation being a really good idea.
Or the arm.
So I can write it down. Whoops. Why doesn't it show up? Okay, and then problems with auto mode. And problems with volume support. And I think that was it. So problems with auto mode, they may stay in PRVC the whole time. And then problems with volume support, if you use volume support to wean the patient, they may need high levels of pressure support. Move out of my way. To maintain tidal volume. Would you expect a patient who has a neuromuscular disease to show respiratory distress if they're having a hard time breathing? Okay, yeah, so you wouldn't see tachypnea, you wouldn't see accessory muscles.
I didn't know for that.
Have a what?
Will they have enough energy to control that? Like that? Younger, if it's from like, that's the one that you guys are going to happen. Even when we try to long to work themselves.
Exactly. They might be diaphoretic. So maybe some tachycardia, diaphoresis.
So they would still have like.
I guess my question was just in general, if somebody has Guillain-Barré and it's affecting their diaphragm, would you expect to see respiratory distress?
It's affecting their diaphragm. Then yes, you would. No, really?
No, you don't see anything because they can't move their diaphragm to breathe.
So you won't see that.
No. So that's why you have to be careful with these neuromuscular patients. They don't show respiratory distress. Yeah, so you'd have to look to see if you see good chest excursion. Well, I mean, if they're on the ventilator and they're breathing spontaneously, you're not going to extubate them and them not breathe. So they would continue to do what they were doing on the ventilator. Yeah, that's true. Yeah. Yeah, if their tidal volumes are small enough, they're not getting oxygen either. So we'll start seeing cyanosis, low O2 saturation.
And that's the only way we would know by the side of the wing down there.
Ask me that one more time. Like, how would we know looking at them if they're?
Maybe that's the only way that we might put it that we should have oxygen.
Perfect. Yes, that's correct. Very good. We've got a patient with respiratory distress. It gives you the ventilator settings, SIMV rate of 10, tidal volume 750, 40%, 5 of PEEP, pressure support of 8. Peak flow rate is 50 liters per minute with a decelerating waveform. Those are normal, right? Normal peak flow. If you're going to set peak flow in volume ventilation, it's 50 liters per minute for the adults. Go like this. Very good. Then you look at the parameters. Peak pressure is 28 centimeters of water, spontaneous tidal volume 200 mLs. The total respiratory rate, 35 breaths per minute. We've got an IE ratio of 1:1 and a minute volume of 11.5 liters. That's a little bit higher than our normal range, right? What do we expect for an acceptable minute volume? Yeah, 6 liters a minute is a normal amount of minute volume for us because we have normal lungs. If we see up to 10 liters per minute, it's like, okay, that's increased, but you know, you can do 10 liters a minute and survive without a ventilator. So once it's over 10 liters per minute, we start thinking, hey, that's a pretty high work of breathing there. You know, having to move 11.5 liters of air every minute just to maintain your blood gas, you get tired. So that's a clue. The high respiratory rate, that's not good. Small tidal volume. Assessing the patient, you see increased work of breathing, paradoxical respirations noted. What causes paradoxical respirations to occur? Atelectasis? No, it's chest and belly.
Diaphragm, it could be neuromuscular, could be diaphragm or something.
You won't see any paradoxical breathing. You won't see much breathing at all if their diaphragm isn't working. What about low lung compliance or airway obstruction? Is that what you were going to say, Tijin? Yes. Yeah, so instead of pulling air, like the negative pressure that you generate to pull in air, if it's hard to get the air in, instead you pull in the belly. So during inspiration, you see the belly go in, and you're not supposed to see the belly go in during inspiration. So if the belly is going in, you've got paradoxical breathing. It's opposite to the way it's supposed to be. What do you think about the blood gas? Normal except for oxygenation. Yeah. A lot of VQ mismatch to have to move 11.5 liters and have a CO2 of 43. If you moved 11.5 liters, your CO2 would be down to like 20. So yeah, this person must have a lot of EQ mismatch going on.
So my question for the patient with this ADQ, so would we want to adjust SIOT 8.5?
Yeah, to settle for PaO2 68
Because I'm kind of low for an adult.
on 40% and 5 of PEEP, what would you bump it up to? Yeah, would you bump up the PEEP? Would you bump up FiO2?
I bump up SIOT first because their PEEP, I need to go with more information. So like what's their blood pressure? Like there's certain things that you can affect. So I probably would try 0.5 SIOT first. and see if it's good.
Okay, anybody else?
After you hit 50 and starting.
Very good. Yeah, typically you get up to an FiO2 of 50, depending on what hospital. It might be an FiO2 up to 50, FiO2 up to 60. That's, at that point, you start increasing the PEEP. Anything we want to do for that high respiratory rate? Oh, no, you're not one of those, are you? I can't tell you how many times I've seen that in my career. 68 PaO2, no. If their PaO2 was less than 60, then yes. Pigeon? Okay.
I was gonna say if maybe adjusting the I ratio at all to like.
So you would change the I time?
Well, I'm just asking like another additional thing, because usually I ratios aren't 1 to 1.
But the person's breathing 35 times a minute, so you'd have to have a really, really short I time to not have a 1-to-1. Okay. All right, so more pressure support is needed, right? To get some bigger tidal volumes in there. If you have a bigger tidal volume, does that slow down the respiratory rate? All right, so problems, it says small tidal volume with pressure support of 8. We identified that. Patient is tachypneic, we identified that. Could it be because of a secretion buildup? That could definitely cause a lot of EQ mismatch. What about low lung compliance? Is that possible? We see paradoxical respirations and peak pressure is 28. I guess just the paradoxical respirations tell us that we may have low lung compliance. And then we also address the low PaO2 on 40% and 5 of PEEP. Okay, did I go past that too quickly? Did we address everything? What is the cause of hyperventilation? We have a patient in CMV, which is assist control volume control. Their rate is 12 breaths per minute, tidal volume 700 ml, FiO2 is 0.6, the PEEP is 8. Peak flow rate 60 liters per minute with decelerating waveform. Is that a good peak flow rate for patients with volume control? Um, 50 to 60 liters per minute for a peak flow with adult ventilators. Yes, okay. All right, your ventilator parameters show the peak pressure is 28 centimeters of water. Total respiratory rate, 35 breaths per minute. IE is inverse, 1 to 0.8. Minute volume, 21 liters. Air trapping is noted. The patient has a normal work of breathing. Tachypnea is noted. So it doesn't sound like the patient is needing all these breaths of air. And when you look at the blood gas, doesn't that make it pretty obvious that the patient doesn't need to be breathing that fast? So what could be causing them to breathe 35 times a minute? They don't need to breathe that much. IE ratio is not, IE ratio is a result of breathing fast. It doesn't cause you to breathe fast. Yeah, could there be a leak somewhere causing extra breaths to be delivered? Judging from the blood gas, yes, because the patient doesn't need to have a CO2 of 28 and an alkalotic pH. So anytime you see a respiratory alkalosis, always keep that in the back of your mind, that you want to check the circuit, you want to check your cuff leak, and you want to check your sensitivity setting. Maybe if you catch a leak, that would stop the hyperventilation from occurring right then and there. And then maybe the trigger sensitivity needs to be less sensitive, and maybe that'll stop all these extra breaths. Yeah, circuit and leak around the cuff. For the pressure support breaths, yes, but there's no pressure support in ACDC. But yes, you're correct. Okay, what are the recommendations, Ms. Bean?
And schedule that and then the list of the
Ah, okay. Ah, okay. Yeah. Yeah, pressure support is such a nice mode. It's so comfortable for the patient. It gets rid of a lot of the issues of us trying to adjust the eye times and get them to meet the patient's needs. When they're in pressure support, they have a lot more control over their tidal volumes, eye time. So yeah, it's definitely more comfortable for them. So yeah, we could have a respiratory alkalosis because of damage to the brain, and the brain's response is hyperventilation. Would you increase the set rate? So in assist control, volume control, even though the rate is set at 12, if the patient initiates breaths 35 times a minute, it doesn't matter what the low rate is if they're breathing 35 times a minute. I need you to understand that before I go on. Does that make sense? When you're in full support and somebody's breathing 35 times a minute, it makes no difference if you change the set rate from 12 to 15 or 12 to 18. They're still breathing 35 times a minute. They're not getting down to that number. Yeah, they'll always breathe over it. So increasing the PRVC rate does not help somebody who's breathing really fast. Nope. Nope, not at all. I hope you understand that and you can teach people in the future because it's misunderstood a lot. I've had doctors, patients in assist control, breathing 35 times a minute. They're breathing too fast, turn the set rate down to 8 per minute. Doctor, that's not going to help. I said, turn it down. So I turn it down. Of course, the patient continues to breathe 35 times a minute. So it doesn't make a difference. In SIMV, it does, but not in full support. Is hyperventilation from a low PaO2? 120? Nope, so we can't say that's the reason. Is hyperventilation from a head trauma? Possibly. Did it tell us what was wrong? No, it didn't tell us. So it could be head trauma. Would you recommend sedating the patient? Could it be anxiety? Yeah. Yes. Okay. Would you check the circuit or airway for leaks? Yes, we talked about that. Patients on SIMV with a rate of 4. So they've been weaned down to a rate of 4. They're probably ready for extubation. Tidal volume 500, pressure support is 10, FiO 2.35, total respiratory rate 24. 24 on a ventilator is good, right? I know that's defined as tachypnea. If you have a patient breathing 24 times a minute on the ventilator, we're happy with that. So that's okay. Minute volume 9 liters. What about that? The nurse informs you that she's going to sedate the patient. Is there a danger in continuing with the same vent settings? Yeah. Then the respiratory rate goes down to 4 breaths per minute. Very good. Very good. No, we have to ask you, and you have to know this. You can't graduate unless you know the answer to that. Say it louder. Begins with a P, is that what you said? Oh. Oh, I thought you said it begins with a P. Wisbean says it depends on the type of sedation because some sedatives don't affect the drive to breathe. And Rachel said she knows, but she doesn't know which one it is. Precedex. What about propofol?
Yeah.
It will affect the drive to breathe. So propofol has to be off, but Precedex can be given. Brent, I'm not writing anything. Are you okay? Okay. We have a severe oxygenation deficit. So it gives you the vent setting, 70%, 15 a PEEP, PIP 30. It's not giving plateaus in any of these scenarios. So we don't know if the peak pressure is high because of airway resistance or is peak pressure high because the alveoli are stiff. 30 isn't bad. Isn't it like the maximum acceptable? Yeah, if the plateau is 30, that's bad. Oh, yeah, that contributes to the peak pressure of 30. That's right, our driving pressure. Oh, we don't know the driving pressure because we don't know the plateau. But delta P of 15. All right, so the patient is sedated on propofol. What do you think of the blood gas?
PaO2 is only 52 with an FiO2 of 0.7 or 15.
Yes, we've got problems. What should we do? Go to 80% or 90% or 100%? That's what you were thinking? Like what? Very good. Pigeon?
because once you've already reached, the FiO2 that high, you've already gone. So you would want to put different foods that'll help, so that way you're not taking.
So Bivend has a really long inspiratory time, and that tends to pop open all the atelectatic alveoli. So if they're not oxygenating with conventional ventilation, sometimes you switch over to Bivend, and now the alveoli open. And then you start oxygenating a lot better.
This person might have like air.
What's that? They're not supposed to be sedated for Bivend because we want them to breathe spontaneously along with the settings. APRV is Bivend. What are you thinking of? Tiffany? If you have a peak pressure of 30 and a plateau of 28. So you don't have much airway resistance, but you have stiff alveoli.
Yeah. Also, it's right, is that one person and here, you know, so
Yes, mostly, yeah.
So would ECMO be a possibility? We could do oxygenation index, find out if we come up with a high number, and then recommend ECMO. Oh. Oh, you're right. Wisbeam would have had it and we would have been on ECMO already. Pigeon? You could answer that, and it would be an acceptable answer. It is what you're going to see at the bedside. Is it a good answer? Not really. I mean, you're causing toxicity in the lung, in the alveolar tissue, but you will see it being done. Incorrect. If they need it, you're still causing toxicity. You're still getting those free radicals that damage the tissue, even if they need it. Yeah. No. No. So high percentages of oxygen in the alveoli damage the alveoli. Doesn't matter how much of that oxygen gets into the blood, that pure oxygen causes a lot of free radicals to be formed, and the free radicals just damage tissue, inflammation occurs, edema gets worse. So yeah, it's not a good choice, but it might be the only choice, and you may see it being done. Oh yeah, why not go higher than 15? Might impede venous return? No, 15 has been like the highest that you've seen.
never seen the
I've
data.
seen it 10.
Oh,
I've never seen it.
how high? You have? Yeah. Yeah. If the PIP is 30, I wonder what the plateau pressure is. Because if plateau pressure is close to 30, then yeah, we're causing a lot of lung damage. Ventilating with a 700 ml tidal volume. Yeah, why not 4 mLs per kilogram? Mm-hmm. Yeah, give a faster rate, a lower tidal volume. That's huge. Yeah. Or ECMO, yeah. I think if you're at Memorial, I don't know what their criteria are. Actually, I'll be telling you in a lecture coming up. But yeah, if it's been just a few days on the ventilator and they can't oxygenate, they're talking to the family about ECMO. So. Is the high minute volume causing respiratory alkalosis? Not really. Looks like the bicarb is causing a little bit of alkalosis. So no. Is oxygenation acceptable? 52. What is the SAT? Oh, 88. So no. Would you increase FiO2? We talked about that. You could, but again, the oxygen is toxic to the lungs. Would you recommend a switch to bivent? Yes. Would you recommend oh, we didn't even think about high frequency. Yeah. Oh my gosh. Yeah. Yeah, an article came out a few years ago saying that it doesn't help mortality at all. It's a waste of time. I mean, it's been rebutted. I don't know the right word there. But still, you don't see it used much on adults at all. What do they what? I wonder. They're the A's, yeah. Ah. One of the patients just wasn't oxygenating well, I'm like, oh, why don't this is oxygen? It's like only for kids. You're right. Good point. Yeah, if I'm in the hospital, if you guys are around, make sure they don't put me on ECMO. I would rather go there. Probably to prevent atelectasis. If the person's got stiff lungs as they're breathing spontaneously, I guess they don't keep their alveoli open well enough. Yeah. You're right. Well, if ECMO is doing such a good job and the pH is normal, CO2 is normal, why would they want to breathe? Yeah, good point. All right, so do you want to do this one and then we'll take a break?
Yes.
Hypoxemia with a spontaneously breathing patient. 50% aerosol TPs connected to an endotube of a patient who is breathing spontaneously. The SAT is low. Physician asks you to place a PEEP valve at the end of the tubing where the airflow exits to the atmosphere. Would you do it? Explain your reasoning. Remember what a T-piece looks like? You've got it coming, the corrugated tubing coming from the wall with the aerosol nebulizer, goes to the endotube, and then you've got a little piece sitting on the end of it. Tidgen? You can't. You can't, and you shouldn't.
Oh, yeah. That's the whole point.
Yes, that's the answer. Sometimes I just share experiences that I've had. So a doctor asked me, well, 50% is not doing it. How about if, can't you just stick a valve on the end of it and give some PEEP to the patient? It's like, no, you have to have, you can't have any obstruction to flow because they're not going to be able to, get fresh air flowing.
Is that what numbers?
I know, I know.
I have questions.
You are the expert. So an aerosol T-piece on an endotube. You know how you have that 5 inches of corrugated tubing and then you've got the air flowing out through the corrugated tubing? And then the patient breathes in and then they exhale. No, no, just an aerosol T-piece. No, they weren't extubated. They just have a tube in their airway and they are on an aerosol T-piece. You wouldn't. So if they ask you, don't do it. You would stop the air from flowing. How would the patient get a fresh supply of air coming to their endotube if you plug off the end of it with a PEEP valve? Oh, really? You haven't seen anybody with an endotracheal tube not on a ventilator?
The doctor's like, pick her off the bed and put her on the baby. And she's chill.
Both of them be trying to
And
get
she was
this
not
one.
on sedation, she was chilling. The only problem she had was her anchor back somewhere else. I was like, doing out. She was wasn't like that though, she was literally calm. She knew what-
No ventilator.
She knew what was going on. That is our.
It's the absolute worst idea to take somebody off the ventilator and put them on an aerosol T-piece. It's hard to breathe through that endotracheal tube. Why not have a little pressure support from the ventilator? Why would you want to DC the ventilator to just put them on an aerosol T-piece?
I feel like there were other options. And they did it like
Other options for what?
could have done anything.
Yeah, true.
Okay.
Yeah, high flow would have been a possibility. Yes. Yeah.
Do this? Someone did this. Why?
Mhm.
I don't understand the doctor.
Who did this?
It's done a lot.
Why?
The doctors don't get much of an education respiratory wise. So yeah, so some patients that are like they're a stroke and they need to have some sort of an airway because if you take the endo tube out, their airway collapses. Mm-hmm. Yeah. Yeah, and then it's also the last step, you go from the ventilator to a T-piece to extubating. Is the other way that you'll see that done. Oh, really?
Yeah, happy.
Why are we doing something down my thought? Why would we do this?
LMA is usually when you can't get an endotracheal tube in, then you use an LMA.
So if we took out the group and we took that patient, to see the aerosol, would we use, aerosol mask or bench mask?
If you extubate,
Yeah, it's from the group.
aerosol mask. Yeah.
That's what that is like.
Didn't you guys have to do this in your equipment lab first semester? You didn't do an aerosol T-piece before extubating?
We did, it's for a checkoff, but in our minds, connects to a net, not to a wall. Okay.
Yeah, we don't get it.
We were just doing things, we did it for checkoff, yeah, absolutely, but now that you're saying it's like why?
Well, we never connected it. It's kind of what you're describing, but with a peak valve on the end.
No, there shouldn't be any PEEP valve. Don't
No,
do
I
it.
meant what you're describing. Okay, so basically this with a peak valve on the end.
Yeah, would you do it?
Oh, no.
No, okay,
You wouldn't
very
do
good.
it. I was just asking if this is what it looks like.
Yeah,
So I'm trying to get.
yeah, that looks like a Veni mask adapter instead of a corrugated tubing going to the aerosol. All right, 10-minute break.
Yeah, we're. It's going on.
Okay, moving right along. Is the patient a candidate for weaning? The scenario says a patient with normal lungs was treated for congestive heart failure, is currently on a ventilator, and is now hemodynamically stable. What is the treatment for congestive heart failure? Diuretic is correct. Mhm. Well, the patient's on a ventilator, so. So diuretic, and then what causes the heart muscle to contract more strongly? Pigeon? Very good. Like digoxin. All right, so the patient's stable. On ACVC, rate of 10 per minute, tidal volume 650 ml, 40%, 5 of PEEP. pH is 7.49. PCO2 is 48. PaO2 108, bicarb 29 with a +7 base excess. So is the patient a candidate for weaning? So what do you notice about that pH? It's pretty alkalotic. What's causing the alkalosis? The bicarb, right? Yeah. Yeah, it doesn't say what the patient's total respiratory rate is. So with a CO2 of 48, what are you thinking?
Partially compensated.
They're not breathing enough? So they, are you retracting everything you just said?
Well, no, still with the AC.
They should be breathing less because they're alkalotic, like the pH is high. So they need to retain some CO2 to get that pH back down. Wisbane, what were you going to say? Very good. So say it louder.
It's not a respiratory issue, it's a metabolic issue.
Very good. So the issue here is the high bicarbonate. And high bicarbonate does suppress breathing because the body wants to retain CO2 to balance all of that base. So it will suppress breathing. Do you know the connection between giving a diuretic and having a high bicarbonate?
So, does it,
Not sodium.
so
Yes. When you give a diuretic, it gets rid of a lot of potassium from the body. And when you have low potassium, it gives you a metabolic alkalosis. So you're going to come across this a lot in your patients. So when you see metabolic alkalosis, check the potassium level. Where's the... So I wrote, with metabolic alkalosis, check the potassium level. If it is low, it can cause metabolic alkalosis. So as a respiratory therapist, why do we care? Isn't that a nursing issue? We don't have to worry about that? Very good. It suppresses breathing. So the patient will look just fine, but what they're really doing is trying to retain some CO2 because of the alkalosis.
And the metabolic alkalosis also causes low fluoride as well.
I believe so, yeah. Yeah, I remember I was asked to be an expert witness several years ago. Wow, this is going back more than 10 years ago. And the patient was extubated at a hospital, not one that you guys go to, but hospital in North Miami. The patient was extubated. Couldn't get her reintubated. She didn't do well. Couldn't get her reintubated. She ended up dying, and then now the family is suing. And they're wanting to know if the respiratory therapist did their due diligence at the bedside. Well, the patient had a huge metabolic alkalosis, but was extubated anyway. Can that suppress breathing? Yeah, so that was one of the problems. I guess another problem was the inflamed airway. They couldn't get the tube back in. Weaning parameters were not documented. So, yeah. Yeah. And I said yes to it. And then I got so nervous. It's like, oh my God, I'm going to be standing in court talking about this stuff. I don't think this is my cup of tea. And they luckily settled out of court, and I never said yes again. Am I what? An expert witness? I attempted to, but I was glad I didn't have to be.
General, so.
Yeah, it's nerve-wracking. Marlon?
You guys respiratory therapist monitor? What do we do?
You have to call the low potassium to the attention of the physician, saying, you know, you wrote orders for me to extubate, but I'm noticing that the potassium's really low. How about if we hold off until the patient gets some potassium? Yeah.
Does doctors prescribe that?
To lower the potassium? To lower it.
That way.
No. So we've got a lung resection, renal failure, diabetes, 4,800 ml input, 3,700 ml output. Oof. Where do you think that liter of fluid likes to go? Into the lungs. Breath sounds reveal rails halfway up. Do you know what that means? Rails halfway up. Chris, do you know what that means? Yeah. That's not something that medics use to describe, like when a patient's going into pulmonary edema, you hear a lot of crackling in the bases, and then as it gets worse, you hear the crackling in the middle lobes, and then eventually the upper lobes. No, you haven't heard that before? Oh, okay. So rails halfway up. So there's a lot of fluid in the bases, now moving into the middle lobes of the lung. So all that fluid is coming into the lungs, in other words. Okay, analysis control, 10, 700, 40%, 5 of PEEP. Respiratory rate is 37 per minute. Saturation, 97%. And now we see the blood gas. pH is 7.31. CO2 is 22. PaO2 is good. The bicarb is 14 with a -9 base. So is there any information there that gives you a clue as to why the patient is breathing fast? Very good. That metabolic acidosis is the body trying to correct that acidosis by blowing off CO2. Do we have enough information to do it? One 1.5 times bicarb times what? Plus 8? Yeah. All right, so what is it? That gives us the predicted PaCO2? So it comes out to, let's see, 14, 1.5 of 14 is 21, plus 8, 29. The CO2 should be 29. Oh, really? Ah, okay. The patient is causing the CO2 of 22. Good point. Yeah, I can never follow him when he says, what is Winner's formula? And you come up with a number, and then what do you do with that number? I'm not sure. But this, like Tiffany said, this patient's breathing 37 times a minute. So putting 29 into the formula to figure out the respiratory rate for the ventilator wouldn't help, would it? Oh, no kidding. Ah, okay,
I'm Robert Lee.
okay.
After a while, we got another.
Okay, so now I know the rest of the story. So the problem is the metabolic acidosis, right? That's the main problem going on here. So would you increase the set rate on the ventilator to fix this problem? They're breathing over the rate, and the problem is not respiratory. The problem is metabolic acidosis. How do you fix metabolic acidosis? Bicarbonate. Call the doctor. That's not what you choose. Like when you're taking your national exam, it does that. It says you would, and then one of them is call the doctor. The other one would be recommend sodium bicarbonate. And if you pick call the doctor, you don't get credit for that. Blood pressure. Yeah, if somebody doesn't have good blood flow to the brain, bicarbonate makes the brain damage worse. Yeah, I think it breaks down and causes a lot of CO2 in the cerebrospinal fluid. Wow, good memory. Does fluid retention affect oxygenation and ventilation? So we've got sustained rib fractures on the right and left. Patient's second day in the ICU had 9,500 mLs in and 2,500 mLs out. I wonder if they were doing a fluid challenge or something. Why would they put in so much fluid? Patient is intubated on the vent. There's the settings. Patient weighs 104 kilograms. It doesn't say ideal body weight. Patient is being infused with a neuromuscular blocking agent or Chiron. ABGs show 7.20, 68 CO2, 56 PaO2, bicarb is 20 with a -7 base. What is your recommendation? Very good. So we need to fix all of that fluid retention. And once all that fluid is gone, that's going to improve the oxygenation, improve ventilation. Yes. So I keep going? SOB in the ER. A morbidly obese patient is in the ER suffering from severe shortness of breath. She is currently on a 1.5 liter nasal cannula, is diaphoretic, using accessory muscles to breathe, and is wheezing. The patient is very anxious, states that she can't breathe and doesn't know what she did with her inhaler. Her SAT is 87%, pH 7.35. PaCO2 is 86. She's got a normal pH with an 86 CO2. What does that tell you? Yeah, CO2 retainer for sure. PaO2 is 44. Base excess plus 13. What would you do for this patient? So you would do a Venturi mask instead of a nasal cannula?
Well, you could do it in when you do it, but you could go to 28.
Do you know why that's the better answer?
Because you don't want to give them too much. They go on.
Very good. Yeah. So with a Venturi, even if they have a period of apnea, they're not going to get a bolus of oxygen when they breathe in. It's always going to be that controlled FiO2 with a venti mask. Pigeon? So good question. You want to get your saturation around 90% and be happy with that.
So it's like trial and error.
24%. Mhm.
That 87 isn't that far from 90, right? How much more?
Okay, very good. So 1.5 liter nasal cannula is what percent? Okay, so your thought is, keep the stat of 87%? Really?
But this isn't the normal.
It's a little bit low, Chris, a little bit.
Maybe aim for 93%, since she is a COPD, so I see more of that in the hospital, and someone with COPD, they aim for 92, so it's being like 88 to 93%. Because oxygen kind of suppresses your back to breathe, so.
Yes, very good. Okay, is there any fear in giving Ativan or a sedative to somebody who's struggling to breathe?
Yeah.
Well, I think she's anxious. Sometimes they exacerbate. Because they're freaking out.
Maybe about. Maybe not.
Give Valium instead of Ativan?
For anxiety, that's what he's concerned about.
Oh, okay. I'm not sure which one has more effect on respiration, really. So breathing treatment, yes. Putting her on a venti mask is better than a nasal cannula because you're giving a specific FiO2 and it doesn't change with breathing pattern. So I know on your NBRC exams, if you have a CO2 retainer, you're going to recommend the venti mask, not the nasal cannula, but the venti mask. Bronchodilator. And now what about helping her with her work of breathing? Yeah, does CPAP help with work of breathing though? Wouldn't the BiPAP be a little better? You get that pressure support during inspiration or the IPAP during inspiration. No, you only get that pressure during it, like as you're exhaling, you're keeping a positive pressure. Oh, you're right. So once we put her on BiPAP, we don't need the venti mask. Good point. So that answer would be an or, not an and. Or instead of the venti mask, we would switch her over to BiPAP and then just deliver oxygen via BiPAP. 12/6 and just look at her tidal volume. It has a good chance of knocking out her drive to breathe if you do that. I see. Could you titrate the amount of oxygen you give her by looking at her pulse ox? Maybe give her enough to get her stats up to 90? And if that is a non-rebreather mask and it only gets the stats up to 90, yeah, you're not going to knock out any drive to breathe. Typically with a pulse ox sat of 90, and then you run your blood gas, your saturation is 88%. So that low of oxygen typically doesn't knock out their drive to breathe. Yeah. How high can you go on a Veni mask before you have to switch over to 50%? So yeah, you're probably by 50%, you're giving enough oxygen. You start at 24, have all your adapters there. Start switching them. 24, 28, then what does it go to? 35 after? 35, 40, and then 50, right? Stay next to them. You'll notice like right away they get real sleepy and groggy and you can't wake them up.
Would it be hard to take a patient off a bypass? Because I know with the ventilator, it's hard to take with a sleep and once brings it up off of that. You become more dependent on it. With bypass, you try to do the same thing then with the oxygen.
I guess the difficulty lies in being a CO2 retainer, you're always working hard to breathe. So when somebody gives you BiPAP and suddenly you're comfortable, you don't want to let that go. So I guess it becomes like mentally, I don't know, addicting. Is that a good word? Feels so good to be on BiPAP and not have to struggle to breathe as much. Yeah, you're going to want to stay on BiPAP. I guess the same thing for mechanical ventilation. But I don't know, those endotracheal tubes are so miserable. There's not that many patients that are intubated that want to stay intubated. There's a few. You're going to come across them, but oh, a pink puffer or a blue bloater? Yeah, so no history, like you don't know the smoking history, you don't know anything about the patient at all. You just see them coming in the door. Can you say they're a CO2 retainer?
Yeah, just like, keep that in your pocket, like, just make sure it's like, you got RTs really do that.
Yeah, so looking at accessory muscle use, that's a giveaway. You know, the shoulders going up and down is a giveaway, the puff. Oh yeah, when they lean forward. Yeah, you got a CO2 retainer. Head trauma, patients intubated for post intracranial hemorrhage, pupils are fixed and dilated, heart rate's fast, blood pressure's low, PRVC 18,600, 30% and 5 of PEEP, patient weighs 75 kilograms. Wow. Respiratory alkalosis, like crazy. What can you do for this patient? I can't imagine with fixed dilated pupils that there's any functioning medulla oblongata. Yeah, that's what I'm thinking too. Right, that's what I'm wondering. So you just make vent changes? Oh, it says no, continue doesn't help us, right? So we would just adjust the ventilator settings. Do we want to keep the patient alkalotic to improve brain damage? It used to be believed that it did, but it doesn't. It worsens neurologic outcomes. Not that fixed and dilated can be fixed, but there would be no reason to have somebody with brain damage getting keeping them alkalotic. So tell me something. Very good. So you would lower the respiratory rate. 75 kilograms, do we assume ideal body weight? So 7 times 8, like 560. Yeah, so maybe a smaller tidal volume to get 8 mLs per kilogram. Oh, is it? Oh, okay. Okay. Did you do the formula? Is that how you, okay. Very good. NBRC question, permissive hypercapnia may be beneficial for a patient with which of the following? So permissive hypercapnia, you don't change the ventilator settings to get a normal pH and a normal CO2. You allow high CO2s, you allow the pH to go down to 7.28, or is it 7.25? No, you're thinking of treating newborns. You're thinking of PPHN. This is not PPHN. This is an adult. You want to avoid high pressures? Taylor? If you have a high plateau pressure, you want permissive hypercapnia? Yes, yeah, good point. So instead of ventilating with even higher pressures, let's settle for the pressures that we have and allow the CO2 to go up and prevent damaging the lungs with more pressure to ventilate. Head trauma, hypercapnia worsens head trauma. If you have pulmonary hypertension, if the CO2s are high, it worsens pulmonary hypertension. And if you have an intracranial lesion, having high CO2s does nothing for the lesion. I don't know how to reason that one. But if you have high plateau pressures, you don't want to keep ventilating with higher pressure because that damages the lungs. So you would tolerate the high CO2s. With a neonate, it would make the pulmonary hypertension worse if you have a neonate and you allow a respiratory acidosis. It'll make the pulmonary hypertension worse. Mm-hmm. Yes.
Allow the pressures to not increase. Would I write that to you or an instrument that would allow the pressures to not increase? What would I put this?
So with a high plateau pressure, we don't want to further damage the lungs. By delivering a higher pressure. So we allow the CO2 to be high and the pH to be acidotic. Is this the last one? So is this a ventilator associated event? It tells you to remember that a VAE is flagged when there is an increase over the baseline period and the daily minimum, and it's FiO2 and PEEP. So if FiO2 has to be increased more than 20% over 24 hours, that patient gets flagged as having a VAE. Or if PEEP is increased more than 3 centimeters of water, 3 centimeters of water or more in 24-hour period of time, that's flagged as a ventilator associated event. So those are the markers that are being used by, is it CDC? Who keeps track of this? I would imagine CDC. So you guys might see patients on higher PEEP than they need. You might see them on a higher FiO2 than they need. And you're thinking, why aren't they turning down the FiO2? And why is the PEEP left at 8? They don't need 8 of PEEP. Their oxygen is like 160. Why are they? And the reason is, if anything happens to the patient and their oxygenation declines, you won't have to turn up the FiO2. If you don't turn up the FiO2, it doesn't get flagged as a VAE. It's like a cover. Have you come across this where you're wondering, why aren't they weaning the FiO2? Why aren't they weaning the PEEP? Yeah, so on 40%, if you have a PaO2 of, I'm picking a high number, like 150. You say, oh my God, they don't need to be on 40%. Let's turn that down. But if something happens and they need more oxygen and then you have to turn it up, now that becomes a flag for a ventilator associated event. And when ventilators have too many ventilator associated events, I don't know if it affects their reimbursement from insurance companies, but it's a big deal. There's a lot of documentation that goes into these ventilator associated events. Does somebody have that as a topic? Did I just give away your wind? Patient is placed on mechanical ventilation and within 12 hours of being intubated, required FiO2 increases as well as PEEP increases to achieve acceptable oxygenation. Is this considered a VAE? Well, it doesn't say how much FiO2. Doesn't have to be what? Oh. Okay. So it's not telling us how much the FiO2 was increased, so that didn't help us. It's saying within 12 hours, but only if it stays with the high FiO2 for more than 24 hours. So we can't really answer that question, can we? Okay. Okay, so it's 5 to 4. I feel like your brains are fried. So what should we do? I don't think we're going to make it through all three topics at this point in the day. There's one that's short. Healthcare reimbursement. Yeah. So then next week we can just do the rest of this? Okay. All right, so you vote for one short one? So I'm trying to avoid you guys having to use gas money to come here next week. So I'm thinking Zoom, if you guys are okay with Zoom, I'm okay with Zoom. Yeah,
Are you gonna record it?
yeah,
Okay.
yeah, so I'll be here because I have to be. But I'll have the recording on and you guys can participate, but you just won't have to drive up here. I mean, to drive up here for, like an hour and a half of lecture.
And we do need to meet with you next week about our topics as well,
Are
right?
we able to do that on or the time of year?
Yes,
I gotta come up here anyway. It's either-
that can be done via Zoom.
Okay.
Yeah. Yeah, as long as you can share your screen, like if you have all of your articles on your computer screen and you share your screen and I can see your articles, then you don't have to come in.
gotta come up here.
Okay,
Can we just come in?
yeah, absolutely.
What time is the class?
At 1:30?
So, okay, then we have, and then we just show you our articles and that's it, right?
So, yeah, if you're gonna be here live next week after I finish the topics, then we can sit down and talk about your articles, yeah? Okay. So, I will send you a sign up for when you're gonna show me your articles. Sound good? All right, well, have a good rest of the day.